Hi, everyone. My name is Erin Das, and I am the course coordinator for the Introduction to Palliative Care for Humanitarian Healthcare Workers. And we're currently in our second week. We wanted to just acknowledge and say thank you to everyone who was able to come last week, Tuesday. And it's great to see that so many of you are joining us again today. This week, we will be having our topic presentation, followed by a case presentation. And this is the way that most of the sessions will run for the consecutive 11 weeks. As you can see, many people are joining the call, and we have asked that you rename yourself to the name that you registered earlier a few weeks back. We did have some great attendance last week, and we were able to acknowledge that 122 of you as participants attended the course, which is great. So please do make sure you take the moment now to rename yourself. If you are also interested in connecting with our faculty, I have renamed our faculty with the hashtag right in front of their name. So if you're looking for a faculty member that possibly works in your area or someone that you wanted to connect with, you can find our faculty with the hashtag in front of their name. So any faculty that are on the call now, you can also rename yourself. That would be great. Just a reminder about our Zoom protocol. We do ask that everyone stays on mute. We will have lots of time for discussion. There's about 30 minutes for a large group discussion today. So we'll take a lot of time to allow each participant, if they want to share a case or share information that they're wanting to learn. But it's going to be during a specific time. Please make sure you remain muted for the times during the presentations by faculty members, just to keep the background noise less. So welcome to everyone. We are on our second week, and today we're going to be having a general overview of what is palliative care. I hope you had the chance to listen to the YouTube video, but now I'd like to take the moment to introduce Dr. Zipporah Ali. She is a pioneer in palliative care here in Kenya, and she's very passionate about supporting humanitarian healthcare workers to provide palliative care in your own work settings. So Dr. Ali, I join you now, welcome you now, and I'll give you the floor. Welcome.
Thank you very much, Erin. Good morning, good evening, good afternoon, wherever you are. We'll be looking at what is palliative care. Mostly want to understand what palliative care is, the definition, and where it's applicable. So the time is short, but we'll try to manage this within the time we've been given. And thank you, Erin, for this opportunity. Just let me move to a slideshow. Are my slides visible?
Yeah, you're good.
These lab guys have become very.
Okay, there's a lot of background noise, but so we'll be looking at what palliative care is, and I hope that by the end of this session, I'll put my camera off so that I don't have internet, my internet unstable, so that at least I can put on later on. We'll be looking at what is palliative care, the definitions of palliative care, the principles of palliative care, who benefits from palliative care, what conditions, and also the gaps that we come across in our places of work, or maybe even at a national level, and how to apply palliative care in humanitarian conditions. Like I said, there's a lot to be taught, but we'll try to pretty much have an overview of what we need to know. And of course, as students, and we can always learn more on our own as well. So I think last week, Dr. Esther Nafula talked about palliative care, the definition of palliative care. And we remember she focused on the fact that WHO has a definition for palliative care that was developed in 2002 that focused a lot on patients and their families. It doesn't just extend to patients only, but it extends to patients and families, because when patients are unwell, family members and their loved ones also get affected. And also, I think she also specified in her definition that it's really palliative care is for people with life-threatening illnesses, and we have to prevent and relieve their suffering by means of early identification of what their needs, and impeccable assessment. By impeccable, we mean thorough assessment, especially of their physical, emotional, spiritual needs, not just physical needs, but all the needs they might be having. And of course, once we do an assessment, then we need to treat the symptoms they have. Most patients, for example, if they're cancer patients, will come with moderate to severe pain that needs special medications for pain management. And I think you have a session on pain management. So you'll be looking at principles of pain management. And of course, it's not only pain. Like I said, there are other problems patients can come with. They could be psychological, spiritual, and I usually add financial, especially for people from low and middle income countries. By the time a patient comes to the palliative care center or unit or hospice, they have spent all their money, and so they are also in a very bad place financially. So again, sometimes you might have to address their financial needs. So if you look at the definition of palliative care and you break it into components, it actually talks about pain, relief from pain and other distressing symptoms. Patient can come with a variety of symptoms, so we need to be able to address each symptom separately. And also it talks about palliative care affirming life and not regarding death as a normal process. And sometimes when we say this, people think, oh, are you talking about euthanasia? No, I just want to clarify here, we are not talking about euthanasia. We are talking about walking the journey with the patient where we can cure the illness, we try to cure. And even if you're not able to cure, we actually try to relieve the symptoms and suffering. So also I mentioned earlier on that it's not just physical, but psychological and spiritual aspects of patient care. And at the same time, remembering that the patient has a family, has a system at home that takes care of them, their loved ones, they could be friends. These are also very important, and we need to be able to address especially the emotional, psychosocial, spiritual needs. And again, one of the things that is very important to remember in palliative care is that the patient's needs are very many. You talked about the needs, whether they're physical, sexual, spiritual. One person cannot really address all those needs. So we work as a team of doctors, nurses, clinical officers, pharmacists, medical social workers, support staff, even the patient and the family are part of this team. So it's actually a multidisciplinary approach to care. And then, of course, one of the things that sometimes we forget is palliative care is given from the time of diagnosis. So we don't wait until a patient is dying, then we send them the palliative care team. No, once we have a diagnosis of a life-threatening illness, of a terminal illness, then we need to, to work together with the palliative care teams, or ourselves as clinicians, we need to understand that we need to provide palliative care for this patient. So it starts from the time of the diagnosis and it continues throughout, even if the patient is undergoing treatment for the illness. For example, if they're at an early stage of cancer and they're undergoing chemo, radiotherapy, whatever, we need to be able to provide palliative care for them. So if you are working in oncology, you have to work very closely with the palliative care teams. And of course, that is important for us to remember that we work together as a team. So apart from just the adult definition of palliative care, a lot of times we forget we have children who have palliative care needs as well. If you look at the statistics we have in my country, in Kenya, less than 1% of children who need palliative care receive it. It's not because, actually it's really because we as healthcare professionals are not referring children appropriate for palliative care, but children also need palliative care. And the definition for palliative care for children talks about total care of the child's body, mind, and spirit. So it's totally holistic as well. And it talks about giving support to the family. When a child is sick at home, the family, or in hospital, the family is totally devastated, because we know children are supposed to grow into young adults, have dreams and live their lives. And then all of a sudden you have told your child has got a life-threatening illness, it becomes very, very difficult for family members and siblings within that home. So it also begins when a diagnosis is made and continues throughout the trajectory of the illness, whether they're going to get well or if they're not going to get well. We continue with palliative care. So we usually leave open doors, because a patient might go away for some time because they're feeling well, but if the disease appears again, then we should be able to take this care of this patient. So again, it talks about the holistic approach, looking at the physical, psychological, and social distress of the child and their family as well. And also talks about the fact that we work as a team, even in children. We don't just work in isolation, because there are very many needs of the child and the family that we need to take care of. And also one of the things that is WHO says about pediatric palliative care is that it can be implemented at every level of care. Some people think that you have to go to a hospital or you have to go to an inpatient facility to receive palliative care. That's not true. Children can be taken care of at home if they're stable by teams that are doing home visits. And so it really very similar to the adult one, but a lot of focus is also given to the children's family, to the child's family. And so we need to remember that palliative care for children is very important, and we should not deny any child palliative care if they are in need of palliative care, wherever they are. So, so if you look at those definitions, just maybe in a nutshell, on a diagram, it talks about the physical, psychosocial, and emotional and spiritual needs. And this is what Dempsey found as the founder of the modern hospice defines as total pain. When somebody tells me all of me is wrong, it might not necessarily be physical. It could be maybe I'm really psychologically, I'm depressed, or I'm asking God, my creator, what have I done to deserve this disease? So you have to look at the patient from all aspects if you're to treat them. You might actually be treating the physical pain and not really getting anywhere because you have not addressed these other pains. So we need to be able to have a holistic approach to our patients so that we address all their needs. So I would go maybe into this, but if you look at this, it talks about the different things that you might need to look at. If you're looking at physical needs, are they functionable? Do they have, are they strong? Are they fatigued? Are they resting well? If you look at the psychological needs, they might be, depressed, maybe anxious, helplessness, fear, all those things happen. And of course, if you look at the spiritual one, and when I say spiritual, I'm not necessarily saying a religion, but I'm talking about spirituality. They maybe have lost hope. They feel like they're suffering. I'm totally suffering. The meaning of pain, the meaning of the illness. Why me? What did I do so that my creator gave me this illness? And some of the things you'll come across when you're taking care of patients. Of course, social burdens are very important. Like I said earlier on, this includes the financial burden as well. Patients will have spent all their money to get well, and then they are not getting well. So they have deficits in their budgets. And especially if they're in humanitarian situations where they don't even have means of generating income, they have more problems than the ones who probably are not in a camp. So again, we have to look at the 4 dimensions of care when you're taking care of patients. So this is just again summarizing what we talked about, pain management. And the picture, the top picture is actually of a nurse in Nyeri Hospice doing a home visit and dispensing oral morphine for the patient. So we need to have the necessary drugs that we should use for controlling pain, and we'll be talking about that when we're doing pain management as per WHO. And then we also talk about other symptoms. Somebody could come with a cough, diarrhea, constipation, fever, and fatigue, anxiety. All those symptoms need to be treated. And then, of course, like I said earlier on, emotional support. And you can see the nurse here touching the patient on the bed, actually a dying patient, so that they don't feel isolated, alone. And then we also talk about family members. And this is also one of the Nyeri hospices, actually the social worker and the nurse talking to the patient's family, probably giving them information about the illness and how it's going and what they need to do to support the patient, and what also they need to do for themselves to support themselves as well. So it's really a holistic approach when you talk about palliative care. Many benefits have been documented about palliative care, apart from the benefits for the patient, because we manage their symptoms, we facilitate communication between the patient and family and healthcare workers, between healthcare workers. One of the things that we usually see in palliative care is sometimes we fail in communication, telling the patient about their illness. If the disease is progressing, sometimes we are shy to tell them the disease has progressed. And so communication is very important in palliative care. We need to be able to communicate to patients, to communicate to each other as healthcare providers, and to communicate to family members, and even facilitate communication between patient and family, because sometimes there are things that they're not able to communicate to each other. And so we even usually talk about family conferences where we can actually facilitate communication. So it has many benefits for the patient, many benefits apart from symptom management. It has also many benefits for the family members, and even a lot of benefits for the healthcare system. Most of our patients come to the hospital because they have a symptom that is distressing them. They might come because they are vomiting or they have severe pain. And if we address these symptoms, patients will actually be able to go home and live a comfortable life within their house. Most patients, when they're asked, where do you want to die? We did a street survey sometime back in Kenya. Most people said, I would like to die at home. So most patients would like to be stable and be taken care of at home, unless they're undergoing a treatment that needs them to be in the hospital. So it is also cost effective. Why I'm mentioning that is that it's cost effective for the patient and also cost effective for healthcare systems. And also some studies have shown that people who receive palliative care from an early stage, from the onset of the diagnosis, actually have less distressing symptoms when they're dying, and some of them might live a bit longer than those who have not received palliative care. So it's not just about quality of life, but also it might actually affect the quantity of life of the patient. But of course, we look at the fact that we want to have a positive quantity of life and not necessarily extend life by putting people in the ICU. We try to avoid those situations. So like I said earlier on, all these needs of the patient cannot be met by one. We have many different people working in palliative care. We have especially the nurses are the most important because they spend more time with the patients. We have doctors, we have volunteers who come to do some things for the patients. We have different people, therapists, physical therapists, occupational therapists, and pharmacists are very important because they are the ones who are going to enable medications, and then medical social work and spiritual caregivers. And so, if you're looking at having a good, palliative care setup, we need to look at, do we have these people? Sometimes we don't have all of them because of where we are working, because of finances. So you might find even me as a doctor, I might end up doing what the spiritual caregiver should be doing. So sometimes we actually do what we call multitasking, or sometimes even task shifting because of the where we are working. So this is just to show us what palliative care is, what it was initially. People, doctors, whatever, would wait until the patient, they would treat the patient's illness if they could treat it. And when the patient is dying is when they would refer them to the hospice for end of life care. Now, this has changed over time. And so it is recommended that once you make a diagnosis of a life-threatening illness, as much as you're treating the patient, bring in the palliative care teams to help you take care of this patient, because this patient might not get well and their palliative care needs will be more than what their treatment, their curative needs. So once the patient is referred to palliative care, the palliative care teams gets involved. And should the patient start dying or will need end of life care, then we should be able to support them at that very difficult time. And once the patient dies, we also support the family. So we talk about bereavement services as well. So we don't, when our patients pass on, we don't stop, support the family. We support patients' family in bereavement. You might actually find that some of them are having what we call complicated bereavement, so you might need to intervene for such cases. So the other thing that I just thought I should mention is end of life care is part of palliative care. And specifically, I mentioned end of life care by itself. I know we'll be having a session on that later on, is because people think palliative care is equal to end of life care. Even where we work in Kenya, most people think end of life care is palliative care. End of life care is just one component of palliative care. When a patient is, disease is advanced and you realize maybe their organs are failing, if it's cancer, it has metastasis everywhere, patient is imminently dying or maybe has a few months to go, then of course your goals of care change. You're now focusing a lot on making sure this patient is very comfortable as they approach death. You're also supporting the family. So let's not confuse end of life care to be equal to palliative care. Palliative care is the umbrella word, and end of life care is a component of palliative care. So I just thought I should mention that here because we make that mistake a lot. We wait until a patient is gasping, then we refer them to the palliative care team. We should be able to refer them at an early stage from the diagnosis. I'm going a bit too fast. So if you look at the need for palliative care is big, WHO has come up with this diagram that talks about different diseases. And again, here I want to specify that palliative care is not only for cancer patients. We find that most of the patients we see in our setups are cancer patients, yet patients with any life-threatening illness, patients who are going through some suffering because of their illness will benefit from palliative care. It could be because of old age, it could be because of organ failures, advanced illness, and children with also multiple illnesses or children with congenital diseases can also benefit from palliative care. So we don't just say it's for cancer patients only, other patients who have a life-threatening illness. For example, now we have NCDs on the rise, we have hypertension, diabetes, cardiovascular diseases, and so these and respiratory diseases, these are people who can also benefit from palliative care, especially in advanced stages of their illness. And children have multiple conditions that can benefit from palliative care as well. Children might be born with a congenital abnormality. This will also benefit from palliative care. In fact, the diseases for children are listed somewhere, and there are quite a number of them. So let's not just limit our palliative care to cancer patients, but it is beneficial to patients who have got other life-threatening illnesses. So I've just listed a few of them here: cancer, HIV, motor neuron disease. All these are, you'll get the notes later on. End-stage cardiac disease, or let me say end-stage organ disease. All these people will benefit from palliative care, including people with the disease like sickle cell as well will benefit from palliative care. Patients in Burns unit will also benefit from palliative care. So it cuts across many diseases. It's not only a cancer for a service for HIV or cancer. It's a service for any life-threatening illness. If you're thinking of setting up a palliative care service in your country, the WHO has given us, guidelines on how we can actually integrate palliative care into our services. This includes things like education, policy, implementation, and drug availability. So if we look at these pillars, once we have them in place, it's a lot easier for us to implement palliative care services. We need to do a lot of advocacy to our governance, to our policymakers. We need to be able to educate not just the healthcare professionals, but even the public, the media, and also have experts. When we need an expert, we can refer a patient to an expert. And then, of course, we need to have drugs that have been recommended by WHO for palliative care. There are about 35 of them or 34 of them, especially opioids, which are usually not available in most of our setups because of issues of illicit trafficking and all those, and because of the regulations that each country has. And of course, our policy helps. When you have a policy, then it's very much easier to implement these services. So this is just kind of capturing what we need to do to be able to have palliative care services in our country. In 2014, WHO came up with the first palliative care resolution, the first resolution ever, which has talked about countries that are members of WHO should strengthen and implement palliative care policies. They should support palliative care initiatives by providing support to caregivers, that is you and me and even family members, and of course education and training, including palliative to our training curriculum, and ensure access to essential medications. We talked about that, and of course fostering partnerships between government and civil society to increase access to palliative care, and also quality. I think quality is not showing, but they talk also about quality. So but palliative care has now been recognized at a very high level as a necessity. It should be fully integrated into all the healthcare services we have within our setups at all levels of care, not just the national level, but also up to the community level, where we engage mostly with community health volunteers and hospices to be able to continue taking care of these patients at home. So just from what we talked about, maybe you can we can just look at where can palliative care be provided. Some people think it can be only in a hospital. Some want to say only at home. Others hospices, others nursing homes, in refugee camps. You can just be writing notes as we continue. Where do you think palliative care can be provided? Is it a specific place? Is it about mortar and brick, or is it about the concept of providing palliative care? So just think about it as we continue. Where can palliative care be provided? So if you look closely at palliative care and humanitarian situations, we talked about that last week briefly, and I think I shared about a link to this book, which has got very good information on how you can implement palliative care in humanitarian conditions. In 2015, the United Nations Office actually said that we have about 120 million people, in humanitarian situations who need assistance. Now, out of these 120 million people, I wonder how many of them require palliative care. How many of them have got a life-threatening illness? There must be many. So again, it also says that responses to humanitarian emergencies and crises rarely provide palliative care. So we may be failing our patients because we are focusing a lot on treatment, emergency acute conditions, and we're forgetting that even these ones we are looking at might need palliative care. And even in these conditions, we have people who have chronic illnesses that might need palliative care. So we sometimes forget that palliative care should be fully integrated into the services we are giving in humanitarian conditions. So the other thing is that, of course, we are told that people living in low and middle income countries are very vulnerable to unnecessary suffering and will need a lot of palliative care. And last week, I think I mentioned that whereas 80% of the people who need palliative care live in these countries, 80% of palliative care is provided in the high income countries. So that imbalance, there's no balance really, and we need to really make sure that also people, wherever we are living, also have access to palliative care. So again, just to remind us about what we talked about last week in terms of need for palliative care. So I was reading, and there was this Red Cross, proclaimed 7 fundamental principles of palliative care. I won't mention all of them here, But when you'll be doing ethical principles and professional issues in palliative care, you'll actually come across, you'll probably deal a lot on some of these issues. It talks about humanity. And this is really preventing and alleviating human suffering wherever it may be. It shouldn't just be in a place where it's safe, but it should be anywhere the patient is where the patient is. We should actually be able to prevent suffering, because it's a human right to not suffer. It talks about impartiality, making no discrimination. We should not discriminate whether a person is a male, female, or has a gender issue, whether the person is black, white, yellow, whether the person is religious or not religious, whether they're an adult or a young person. Actually, everybody should have access to palliative care. So it's not discriminative. It's a service that should be provided to anybody who is suffering. It talks about neutrality, not taking no sides. So again, we have to realize we are not taking sides in terms of when you're providing care to these patients, but really, supporting patients when they need us to support them. And then, of course, it talks about autonomy, maintaining autonomy. Autonomy can be expressed as autonomy of the patient, autonomy of the family member, autonomy of the caregiver. But like I said, later on, you'll actually be looking at ethical principles of palliative care, and you'll understand more about these issues when you look at that subject. So let us just reflect, do some reflection, and you can also put in the chat, what are the gaps we see in patient care, where you are, where you're working? What are the gaps that you have identified in patient care? And then also, what are the gaps in family-centered care? Can we maybe chat about it a little bit? Are there gaps, or are we okay? I can see many things coming in. So we'll look at that later on, maybe. Erin, we'll look at the gaps that they're talking about later on. So
yeah.
So I was just asking, we reflect and talk about them, so that we will be probably discuss that in the later, a few minutes later. So I know we face challenges in terms of taking care of palliative care patients where we are working, and how do we address these challenges? So some of the things that we are hoping that by the end of this whole course, you'll actually have been able to identify those gaps and even come up maybe with a plan on how you're going to address some of those challenges. It might not be possible to address all challenges, because the issue of human resource and also funding can be very challenging, and education and training of healthcare workers can also be very challenging where we're working. So we need to look at the end of these sessions, I hope we'll be able to understand, not just necessarily this session, but the whole of this course, we'll be able to have understood our gaps and challenges, and also maybe come up with a work plan on how we can address these challenges to ensure that patients receive palliative care, even if they're not living in their own country, but are living in different parts of the world because of what's happening maybe within their own country. So this I borrowed from the previous, from the two YouTube video that we actually watched earlier on. It talks about gaps in patient care. Some of them are symptom burden, which are unaddressed. And this is, of course, when a patient comes in with severe pain, for example, cancer pain that needs oral morphine. Do we have oral morphine in a place of work? Do we have other drugs management? Do we have all the drugs we need? So again, patients will have a lot of symptoms sometimes which you're not able to address because we don't have the right medications to address these symptoms. And again, like I said earlier on, lack of communication. Communication is very important in palliative care. Communication between the patient and the family, the healthcare worker and the patient and the family, and even among the healthcare workers. If we don't communicate well, usually have a lot of problems. So communication is very important, especially for healthcare workers. Things like breaking bad news. Some of us find this as a very big challenge. We're not really sure that we can do it the best way. So I'm hoping that also there'll be a session on breaking bad news, so that we can understand how we can communicate with our patients. And again, preferred location of care. We talked about where can palliative care be provided, and we said it can be provided in many setups. It's not about brick and mortar, but again, you want care to be provided in a place where you feel comfortable, in a place where you feel loved. Most of our displaced people are in camps. They don't even have maybe family units in those camps. They might not even have somebody from their home region. So it's not really usually their preferred place of care. They would like to be in their home, in their country, without war, without any issues, and to receive palliative care where they are. But unfortunately, this is not so for most of them, because they are mostly displaced and cannot sometimes even go to hospitals within the country they are in, because they are not nationals of that country. So again, of course, disease pathways are not known. And I think I mentioned this last week that somebody has a diagnosis of cancer, an early diagnosis of cancer, but of course will not be able to assess treatment because they are displaced people, they're not citizens of that country, they don't have any health insurance, and also because of a lot of issues in terms of funding, and also even traveling to a referral center, a center of excellence for treatment would be also a very big problem for these people. So again, I borrowed again this slide. It talks about gaps in family-centered care. This is again, families, remember, are members of the people, families of the patient. But sometimes it's not just families, but patients might actually even be closer to their friends than they are to their families. And so they might even tell you, my next of kin is my friend, because that's the person who I think has my best interest at heart, and the person I am, I'm comfortable with. So again, we need to support the people who are around the patients, their family, loved ones, because they're going through a lot. They're going through a lot financially. And so sometimes when the patient will tell you, the family becomes a financial burden to them. So again, family members and loved ones can actually go through a lot, even communities as a whole. We live in setups where I think within these setups from my visit to Kaguma and Dadaab, I actually, people sort of set up communities. If you're coming from the same region or same ethnic group, you group yourselves together. So even these people might need support as they're taking care of their patient as well. And so education to people who are taking care of patients, they might ask you, when do I give the medicine? How do I address this wound? We should be able to give them that information as well, so that they also feel they're part of the team that's taking care of the patients. Again, just like we said in terms of patient gaps, again, preferred location of care is not, of course, the ideal place they would like to be. They are displaced people, as you remember. So palliative care can be given by a general doctor, and that's why it's important that as healthcare providers, we should advocate for palliative care to be integrated into our undergraduate curricula, whether it's nursing curriculum, medicine curricula, or pharmacies, medical social workers, all these people who take care of patients. We should actually include palliative care into the curriculum so that you can take care of the patient. Even as you look at where do I next refer this patient to, you should be the first point of contact to provide the necessary palliative care patient needs. And so we need to be, to be able to train our healthcare workers to understand what palliative care is and to be able to provide it when necessary. And then, of course, for patients who are very sick, we might need a specialist. And I know this is very tricky because we have very few specialists. Especially, I'm talking about Africa. We have very few specialists in Africa in palliative care. I do not know if you have enough where you're working, but if it's possible, we should also encourage that our countries, recognize palliative care as a specialist and encourage clinicians to actually specialize in palliative care. I know Kenya has recognized palliative care specialists and also is encouraging a lot of people to train in palliative care. And of course, when it's very complicated, then we need to refer this patient to a center. But the most important thing to remember is that palliative care should be available at every level of care, whether it's at the community or at the highest level of care in the country. So we should be able to integrate it into every level of care. Again, just looking at some of the things the WHO talks about, the fundamentals of palliative care for humanitarian situation is that we should focus on relieving human suffering. So I know when you are working in a camp or you're in an emergency or crisis, saving lives is what you're looking at. But again, as we are saving lives, we need to remember that even those whose lives you're saving will probably benefit from palliative care, and those who need palliative care should be able to access it. And of course, we're talking about symptom management, and symptom management, especially for pain management, which is a challenge. We should have the correct medications. And so I found this very interesting, and I read it the way it is because it's a long sentence. It says, in humanitarian emergencies and crises, the statement that palliative care regards dying as a normal process and never intends to postpone death, that's from the WHO definition, require additional clarification, because people might say, we're not going to postpone life, but what about if a patient can actually benefit from because we're not going to, to postpone death, but what about if a patient can benefit, and actually you might end up postponing death. So it talks about that in this setting, any clinician, including those trained in palliative care, should make every effort to save the life of any patient who may be savable. So it doesn't mean when we say we don't postpone life, it doesn't mean we let patients die. It simply means that we do what we can. If the patient is actually dying and we know that we've done everything, then again, we should just support the patient through that process of dying and not necessarily now take them to a higher level of care and put them in ICU and really prolong a very difficult situation for the patient and the family members as well. So I'm just about to finish, Erin. I know my time is over here. So I think I think this sentence that is from Cicely Saunders, the founder of the hospice movement. For me, it has actually been what has helped me when I'm working and almost sometimes giving up as a clinician when I work with a hospice. I think when you see your patients smile, when you see the family members smile, when a patient comes to you the next day and says, "Thank you, you relieved my pain. I was able to, eat. I was able to sit with my family. I was able to sleep." That's what really counts. That we touch a life and make, put a smile on somebody's face. And so she says, "You matter because you are, and you matter to the end of your life. We will do all we can, not only to help you die peacefully, but also to live until you die." And I always say, it's not just, we shouldn't just take it as a sentence. Whatever you're doing to your patient, if you're injecting them, please do it with, in a manner that you're not going to hurt them. If you're doing a lumbar puncture, if you're doing a bone marrow aspiration, if you're dressing a wound, try to make it not a horrible experience for the patient. So whatever we are doing for our patients, we actually have to do it knowing that they are still alive. They are still alive, and they matter until the last minute. And after they have died, we continue supporting their family members in bereavement. So I think this for me usually is something that I've always thought is, it has always touched my heart, that she actually brought this out, that patients matter for as long as they're alive. And we know that after they have died also, we also support their families. Thank you very much.
Thank you so much, Dr. Zippy. I think we all get inspired when we hear you talking, and it's really great as we continue to grow our palliative care community amongst humanitarian healthcare workers. I think these kinds of conversations are really important, that we talk about what the gaps are. We talk about ways that we can continue to improve the care that we give to our patients. And I think we can be very motivated that by Cicely Saunders in her last quote. So today we're not going to do a breakout room, but I do have a quiz for us to do as a group together now. So I'm going to put a quiz on Zoom. It's a poll, and I want you to take about 5 minutes now to look at the poll. We've done a lot of chatting and talking about some of the gaps, but now I want you to take a minute. I'm going to launch the poll now. And I want you to read through the questions, and it's regarding what is palliative care, just to see how you guys are learning regarding the topics that we're talking about today. So the first one is, what is palliative care? And put in your answer. You'll see something pop up on your screen. Read through the answers for question 1 and question 2. I just want to take a minute just to welcome our faculty members that are here with us today. We have Dr. Maha, we have Vicky from Uganda. Dr. Maha, sorry, is from Lebanon. Vicky, the palliative care nurse from Uganda. Dr. Zipporah Ali, who just did the lecture today. I believe Dr. Esther Nakula was here with us. She's from Kenya. And we have representation from Kenya Hospices and Palliative Care Association as David and Makulin, and we have some administrative support as well from KEPCA. So welcome to all of our faculty members as well. So take some time. I see we have some good results coming in. The first question is, what is palliative care? The second question is, which of the following statements regarding palliative care is correct? We'll leave the poll on maybe just for a few more minutes. Try to have a guess at these questions. I think we are trying to instill in our colleagues working in difficult and remote, often limited resource settings, some concepts of what palliative care is. As you work with your colleagues and people who are not able to attend the sessions as you are today, you may be asked this question, and we want to help you have confidence in answering these questions with your colleagues. All right, I'm going to end the poll now, and then we'll just go through this today. All right, so about 60% of you answered the question regarding what is palliative care. So the options were when there is no more curative treatment options available. The next one was when a person has less than 6 months to live, and then when life-limiting illness is diagnosed. And the people who answered the the third answer there is correct. We believe that in palliative care, we want to promote and provide care for people, all people living with any life-limiting illness as soon as they are diagnosed. And that's what Dr. Zippi explained when she shared the image of when to introduce palliative care. And for the second question, about 90 of you had answered, or sorry, again, 60%, which of the following statements is correct about palliative care? Early involvement of palliative care can reduce life expectancy for someone with an advanced illness. Early involvement does not change life expectancy for people with advanced illness. Early involvement of palliative care reduces the patient's quality of life. Or patients who have early involvement of palliative care report improved symptom control and quality of life. And I think through what Dr. Zippi was sharing today, I think we can all confidently answer that question as well as the last option there. That as patients have better symptom control and better quality of life, this is through early involvement of palliative care and referring and integrating palliative care approaches early on. So I hope that was okay for everyone. We now will move into a case discussion. So this is what our program will be like each week. We'll have a time of learning, and then we're now going to go into a time of case discussion where we're going to talk about a specific patient. And I'd like to welcome Nurse Vicky Opia to the floor now. And we're going to talk about a patient. I want you to think of this patient as someone that you might see in your setting. So Vicky, I will start sharing my screen now, but you're welcome to have the floor.
Thank you so much. I salute everybody. Just as mentioned, my name is Opia Vicky, a palliative care nurse specialty in Uganda, particularly working for the refugees in Uganda. Yeah, so those are my names. You can share the next slide.
You're welcome.
Yeah, so there are about 2 questions that we need to reflect on and ask ourselves that what are the causes for this patient suffering, the cases I'm going to show to you. And then the next question is, how can palliative care help the lady in our case today? So we have this lady. She is 35 years old. She has metastatic breast cancer, made to the bone, to the liver, and then to the lungs. She has, on her physical presentation, she has a fungating wound on the anterior chest wall, which is foul, and she has spinal cord compression due to metastasis in her thoracic collar spine. She presented late, and therefore she did not receive any oncological treatment like chemo. Those were some of the symptoms that she really presented with when she came to the clinic. She had pain, a pain in the chest wall, which was due to the tumor infiltrations. And then she also had pain to her back, which was due to bone metastasis. She came when she was breathless. That was due to the lung metastasis, and she had pulmonary embolism, which was diagnosed on clinical presentation. She had poor sleep, possibly due to the uncontrolled pain. She also had loss of mobility. That means she was bedbound due to the spinal cord compression. She had low mood and was anxious about her health. This diagnosis was made 2 weeks ago. Then she came to the clinic. Next slide. Her social history. She's a South Sudanese refugee who arrived in Germany in 2015. Her husband died while she was still in South Sudan. She's a mother with 8 children. 2 of the children died while she was in South Sudan, and that was the age range of the children: 5 years, 2 years, 9 years, 11 years, 14 and 15. And when you look at this age range, this is a typical African setup. And then she had 2 brothers who in South Sudan. The brother-in-law wants to inherit her, because in Africa, when your husband dies, your brother-in-law takes the responsibility of inheriting you. The next slide. And then spiritual assessment, we realized this was a Muslim, and her religion is so important to her. She has always found strength and hope in her role as a mother. Most of us as a mother, we know what we do. And coping with the loss of her husband and children by caring for her other children. She do not know why this is happening to her. Therefore, she's asking the question, why me? Just as many other patients may ask themselves. She has always found faith in God, but is struggling to understand how God would allow this happen to her, because she is a believer. She's afraid of what will happen to her children when she dies off. Next slide. So, reflecting on the question, what could be the possible causes for this patient suffering? Maybe we can discuss it out. Can we
Yeah, so we can take some time. Yeah, we can take some time now for people in the audience. If you are able to and your background noise isn't too loud, you can unmute yourself and share. If you have a lot of background noise, then put it in the chat. But if you raise your hand, then I can call on you. So the questions that we're going to discuss now for the next maybe 20 minutes are, what are the causes of her suffering? And then we'll move on to how can palliative care help. Okay, so I see Muhangi Salam. Did you want to unmute?
Yeah, I have unmuted. Sure.
Welcome.
Thank you. Thank you, Vicky, for sharing with us this patient. My name is Salmo Muhangi, as she has read. What are the causes of this patient's suffering? To me, according to the scenario that Vicky has been describing for us, I see this patient is suffering from emotional pain and spiritual pain. Why emotional? She's wondering how really will her children be if she goes away or she dies? And then the spiritual part, she's wondering how could God let her suffer all this much, yet she's a believer. Yeah, that's my submission. Thank you so much.
Thank you. Bang Bol, I think with MSF. Do you want to go ahead?
Yes, this is a wonderful debate. The cause of the painful for that lady, yes, in every country there is a culture. As my colleague put before, if your husband died, then the brother-in-law, which is the brother of your husband, can take responsibility in a term of everything. including the production of the children. The cause of the pain for that lady, one is emotional, because she lost her husband and she had the children where you can even also know where you can feed them. Yeah, that is the most dangerous thing. Then the second one is also behind or back the home, which is the real home where she came from. She may not know that maybe her parents are still there or not, but she didn't know that because maybe she didn't know where they can even also met them. But the most dangerous thing is emotional pain for her.
Yeah, the amount of grief that she's experiencing, maybe the different losses that she's had, right? Like the children, her husband leaving her home country. I think you're right. A lot of good things are coming in on the chat. If any faculty member wants to comment on things in the chat, you're welcome. We'll take Dam Ya. No? Well, sorry.
Okay. Thank you.
Karibu sana.
I'm Damiano from Uganda. That's
Damiano,
the
asante.
Palliative settlement working with RRC. Basically, when I look at the specific case we are discussing, this client, first of all, is having the physical pain, as it has been really, as we have already seen. However, this pain is also aggravated by the emotions. For instance, this lady is looking at, yes, she's sick, but even the caring husband died, even is just wondering about the death of the children. She just there in with a lot of emotional pain, which aggravates the physical pain she's having. Maybe she's even thinking, if at all maybe the husband was around, or if at all I was in my home country and the husband is around, maybe I would have got a better medical services, but here I'm just suffering, nobody to care for me. Oh, so such feelings worsen her pain. Thank you.
Thank you so much. Yeah, it's a complicated case, and as we go through this course, just 1 minute. As we go through this course, we will have more cases like this, and we would love if you could also share and bring your experience as well. Thank you for sharing. Rita, would you like to unmute? Rita, your hand is up. Would you like to unmute?
Hello.
The connection is not good. Ali, are you there? Yeah, go ahead, Ali.
Yeah, I'm there.
Yeah,
Hello.
would you like to share a comment?
Hello.
Yes, go ahead, Ali. Karibu, welcome.
Yeah, thank you and good evening. It's according to that mother who had those children. The children, they are very few. They are very small according to their age. She is suffering from emotionally and physically and psychologically.
Yeah. Thank you, Ali.
Because
Rita.
maybe it's going to hurt her. Hello. Hello.
Yeah. Continue. Sorry, I think we lost you for a minute.
Hello. Yeah. And she's taking care of the small children. And under the small children, she's unable to get something emotionally and psychologically if the children, the small children, and which is going to provide. So that's she's feeling emotionally and
right. I'm so sorry, Ali. I think your connection isn't so great. So we may move on to the next participant, but I think we all are in agreement the types of suffering that she experienced. Sorry.
Yeah, because that mother, she lost her husband, and she has that small children who are similar ages. They are maybe even the children is they are less than 15 years, most of them.
Right.
They are underage. And you know, and most of the people when they're inheriting, people are not good to one another, most of people's. So, and the husband passed away. So she's thinking of what is going to happen to the next husband. And she's thinking about what are you going to give the small kids, the small children. So she has emotional pain and physically and psychologically. So she needs psychosocial counseling and good palliative care. Yeah.
Thank you, Ali. Thank you so much. We'll just take one more comment and then I'd love to move on to the next question because so many of you are facing patients like this. We also need to now think about how we can integrate some of the things we've learned about what palliative care is. So Rita, do you have one final comment about her suffering?
Yeah, hi.
Welcome.
Sorry, my network was so on and off. I tried getting in, but I couldn't. Yeah, looking at the fate of the mother, I believe that there are a lot of factors in play. From what I've seen, that they wanted to succeed her, the man's side. I believe that she must be standing on her own right now. And now looking at her current situation, I believe the sickness alone affects her psychologically and also the fate of these little children. Given that there are many and they're still of a very tender age, I think it leaves a lot of emotional torture in her, emotional pain in her, then the psychological bit of it, and she wonders what will happen to these children when she's not around, given that she has been the main caregiver of these children. Yeah. So from my own perspective, I believe that it would be key. She would actually need more of the psychosocial support.
Right.
Thank you.
Thank you, Rita. I'm so glad your connection came back. It was great to hear. We'll move on to the second question. Sorry, just wait a minute. So as we think about this patient and as Vicky gave us a very good scenario to think about and discuss, how can we integrate or implement palliative care for this woman? What, of course, we've talked about palliative care being holistic, but what are some medical things we know that we can do? What are some psychological, emotional supports from your knowledge about what palliative care is? What are some things we can do, or how can we care for her? Derek, did you have a comment on integrating palliative care?
Okay, hello.
Yeah, welcome.
Okay, yeah, when I think we've seen that from the case scenario, she had a problem of sleeping because of the uncontrolled pain. When I think to improve that, we need to see how her pain can be better managed. Maybe we need to assess according to what is the measure of the pain, and then how can we like manage it according to the analgesic ladder. Yeah, then also she has breathlessness. Yeah, she has problems with breathing. Yeah, we can assess whether maybe we need to help her get some breathing exercises to know how she can better manage the breathlessness. Then also I would last to I think she's a Muslim, and she was worrying like, why is this happening to her? So I think we could maybe have a person, maybe a sheikh from the Muslim faith, and then talk to her in that aspect and advise her and be able to encourage her spirituality. Thank you.
Right. Thank you. Thank you, Derek. I think it is really important to know that palliative care, as Dr. Zippy was saying, is a team effort, right? There might be things we as clinical officers or nurses or social workers are not able to do, and we do need to reach out to our counterparts who can provide support for others. So thank you, Derek. Selmo, did you want to share something on how we can provide care to this woman?
Yeah, yes, please. Thank you, Derek, for your submission. To add on what Derek has already said, I still feel this lady needs I would say a multidisciplinary team to handle because she seems to have a lot on her. When you look really, deep into this patient, there is also an economical challenge. So she needs finances to really, can I say, to smoothen her management, really. And she needs also a counselor, because she really needs to have trust that even if she passed on, her children are going to stay in good care. That one could help and relieve her as she's on her, I don't know, maybe deathbed, I don't know. That's what I want to say. And then also her spirituality, also she really needs someone to reassure her that it is not her first, she's not the only person who has gone through what she's going through, or whatsoever she's going through. Other people have had it, but this is how God has really arranged it for her. And then she becomes positive of her condition, and then allows anything that God would do for her. Yeah, chances are high. Yeah, that's what I could say. Thank you.
Thank you so much.
You're welcome.
Vicky, did you want to share a few thoughts, and then we'll go to the others that are raising their hands. Vicky, did you want to share a few comments?
Yeah, I appreciate everyone who has submitted in her voice. I want to say these are the really cases that we see when we are handling our patients in our community. They present holistically, and we need to manage them holistically. The case in point right now has got a physical pain, as all of us have observed, that there is social pain, emotional pain, spiritual pain, and economic pain. And as palliative care practitioners, we don't work as an entity. We work in a team, we work in multidisciplinary team that everyone has a role to play. And as palliative care team, of course, there's need for us to reduce the pain, or to support her really no pain at all. And also we need to support the spiritual part of it. A lot of patients ask, why me? Why is it happening? Remember, this is a Muslim who loves God so much. So she has a lot of questions with God. So we need to get somebody to come and pray for her so that she's able to empty out whatever thing she wants to say. And also psychological support, issues of culture is really here in our community. Therefore, we get persons to talk to her, as all of us are saying. And I would think we've really managed this case very well. Thank you so much. Yeah.
Dr. Nafula, is Dr. Nafula on the call? No. Dr. Zippy, how do we, so this lady's been diagnosed with the spinal cord compression. How do we disclose information like that to our patients from a medical perspective, knowing that they will have severe, often not reversible symptoms? How do we engage them? How do we treat that symptom? It sounds like she's already been bedridden for some time. Do you want to comment on that?
Yeah, okay. We know that spinal cord compression is an emergency in palliative care. So it depends at what stage the patient came in, because immediately you make that diagnosis, you're supposed to send the patient to, I'm sorry, I have my granddaughter with me, she's disturbing me. Shut up. Yeah, you're supposed to send the patient for, okay. Yeah, you're supposed to send the patient for immediate, to a higher level of care so that they can easily maybe receive therapy, the treatment that we use for spinal cord compression. You have to put them on high steroids. And if the damage is already done, for example, if they have lost sensation, paralyzed, they are paralyzed or anything, then you have to really do a lot of counseling for this patient, because this has just increased her, will have increased her, her anxiety, her physical symptoms and everything. So you'd have to also address those issues with the patient. And, I know that there would be very many questions from us saying, what did I do to get this? Or, people have discussed those ones, but what do I do maybe if it's irreversible? So it actually depends on the stage of the spinal cord compression. Is it at a stage where it's irreversible? Is it are you making an early diagnosis to be able to refer them to the appropriate treatment at that point of time? Yeah.
Yeah, thank you so much. Just one other comment from our faculty, Dr. Maha from Lebanon, can you comment a little bit on the breathlessness? We may have patients that are coming in with metastatic or advanced disease that show symptoms of breathlessness. How do we support patients with that symptom?
Hi, Erin, how are you?
Hey, thanks for being here today.
Thank you for you. Okay, about the dyspnea that she's having, the drug of choice, as we all know, it's the opioids. So small doses of morphine, we can initiate it. Also, the dyspnea, it's also associated with anxiety. So small doses of benzos, she may benefit from them. Some pharmacological techniques we can use, like fans or cold air, some cold ice cream. Sometimes we advise our patients to eat ice cream just to reduce that feeling. So I think the morphine is the best choice for her.
Thank you.
Thank
We're
you.
gonna get,
Sorry.
yeah, Dr. Ali?
I was just going to add, sometimes also, I used to find sometimes it's very important to teach the patient how to breathe. So you can make them sit opposite you and you touch their shoulders and tell them to breathe with you together. So you teach them how to breathe. But also if she's breathless, I would probably want to, if it's possible, to do a chest x-ray, listen to the chest and see if there's fluid. Because if she has a fluid, then the best thing to do maybe that, then also to, of course, do remove the fluid if possible. But also steroids can help in such situations. So probably you'd have to really find out what's the cause for the dyspnea.
Yeah. Okay, we'll take a few more comments from the group. And then we're gonna have one more interactive quiz before we end the course today. So Gakwaye, would you want to unmute and share a little bit about palliative care, how palliative care can help? Maybe the connection is not good. Dr. James, did you want to unmute and share a few thoughts?
Thank you, Erin, for the opportunity to answer on this question. And I would like to state that every one of us was given a submission. I agree with all of them. So in my opinion, understanding the condition coming from this background, looking at the symptoms, we have pain, we have breathlessness, we have poor sleep. Agreeing with my colleagues here in terms of pain, choosing a proper opioid in order to control the pain. I believe she is also having an anterior chest mass, which is fungal in nature, which could also be giving her pain. So probably a pain management for that, and as well as the dressing, depending on what kind of wound this is. It is very important that we maintain the wound area or the wound site along with pain management. So probably an antifungal application, or at least explaining the daily dressing to her. With regards to the breathlessness and a possible PE, if, like my other colleague also said, referring to a higher setup wherein they will have the provision of having anticoagulation medicines with them for the PE, as well as trying to understand if her breathlessness is caused by some sort of fluid collection in the chest, as Dr. Zippy also explained to us. In terms of poor sleep and dyspnea, which one of our other doctor also explained that it could be because of the anxiousness. So probably considering a baseline anxiolytic to have her come out of the anxiety phase of it. Apart from the medical aspect of this, what I also understand is that she will require a lot of counseling, because maybe the diagnosis happened only 2 weeks back, and the time over the 2 weeks must have been a lot of information for her to take in. So explaining and breaking it down to her so she's able to accept her diagnosis in terms of counseling her and her family with regards to her, how her family is going to be, and how her prognosis is going to be, and how she will require dealing with this on a regular basis. And definitely spiritual, like a lot of us already put in. Coming from a Muslim background, maybe having a priest come in and answer her questions, inquiries, and reassure her about death also being a part of life, so that she's able to accept all of this holistically. And she's mentally prepared for this would be also some kind of, area that we can look into the holistic approach of palliative care. I think that would be all from me. Thank you.
Thank you so much. Thank you so much. I think as we begin to learn different palliative care approaches, I think it is really important that we do, as you all have mentioned, take time to think about patients holistically. Of course, when they arrive at a health center, we do need to think about their physical symptoms, but another large part of palliative care that we are going to teach you throughout this course is how to communicate, how to counsel people through very difficult situations in their lives. And I think that's one of the parts of palliative care that I really value. And I think that's a major part of palliative care that all of the faculty member on this call are very good at. So if you also are in a situation where you have a very difficult case and you don't know how to share or to counsel or to talk to people, I think it's really important that you reach out to us. And that's one of the biggest reasons that we're here. We're a large team, so please don't hesitate to reach out. We'll just take one more comment from Damiano, and then we'll do our final quiz for today. And if you have any specific questions for Vicky or Dr. Ali, please put them in the chat now and we'll try to address them. Or if you have a question for the other faculty members, you can put that in the chat. So welcome,
Okay,
Damiano.
Okay, thank you. For me, I will, as other doctors have already looked at the physical part of it, basically as a mental health specialist, I will look more on the psychological bit of it. When we look at this client, has multiple psychosocial issues. And in order to be able to help her out, we need to put her in the central role of her management plan. How can we do this? One, we have to first area her anxieties by trying to normalize some of the situations she's going through. And also we try to find out from herself, according to the problem she's going through, what possible help can is she in need of. Like you find out her needs at that particular time. Also, you find out how she's finding, like for instance, how did she find the new roles after the loss of the husband? What are the needs she has? So in that, when you find out her needs, because we may be addressing, so you may think that maybe the chest pain is the most painful, but for her, when it's if not her need, say yes, the pain is there, but her main problem is about the children whom she's about to leave behind. So putting her in the central management, find out what exactly her typical needs, then work along with her to see how best he can cope up with the needs she has, and maybe solve those which can be solved, small ones which can be solvable. You work out together along with her to solve them. Then those which are irreversible, then you work up with her to see how best she can cope up with such challenging situations. In so doing, she will be contented that at least she's also has a role to play in her own management, and she will be contented. But even if she passes on, at least there is a person who at least has tried to understand her own problems. Or maybe there is also a possibility of carrying on. How even her children may be in maybe safer hands, depending on the needs she has raised on table. Thank you.
Thank you so much. I think one topic I was thinking about as you were sharing is how to, and this is a skill that comes as you become more familiar and comfortable with palliative care, but is how to give a prognosis to a patient. So if this patient came into your facility and this was maybe the first time or second time you saw her, at some point as a healthcare team, we actually need to begin to think about prognosticating or giving a prognosis to patients that have very advanced disease. Again, we do need to take this into cultural consideration, but as a medical team, we we all need to come together and decide, because as you're saying, she has a lot of dependents at the moment. And although her brother-in-law has said that he will inherit her, like many of you have shared, it might not be a final solution for those children. So as we think about the big picture, as we think about how best to support her, sometimes we do have to make some pretty difficult, conversations, even amongst our healthcare workers, and in terms of sharing a prognosis. And when we talk about prognosis, we talk about how long we believe that she will live for, based on her advanced disease and her symptoms. Hopefully Dr. Ali will be around for the next several classes so she can give us her advice. She's been working in palliative care in Kenya for many, many years now. So she will obviously have had a lot of experience along with our other faculty that are with us today. But these are the types of skills that we're hoping to instill in each and every one of you. Okay, so I'm going to put another quiz question on. We have 3 questions for this quiz. And again, if you have any, questions that you'd like the faculty to answer for today, please don't hesitate to ask them on the chat. So I'm just going to start the next quiz. It's 3 questions. So please begin to answer them. We'll take a few minutes now. So hopefully on your screen, the quiz has popped up. There are 3 questions. The first question is globally, which is the most common diagnostic category of adults needing palliative care? Number 2, all individuals with life-limiting conditions require specialist-level palliative care. And number 3, which of the following statements describing palliative care is correct? Okay, we'll just take maybe 10 more seconds to answer. Looks like nearly 70% of the participants have answered, which is great. Okay, I'm going to end the poll now. So hopefully you can see the answers. So for number one, globally, which is the most common diagnostic category of adults needing palliative care? Actually, the correct answer is cardiovascular disease. Around the world, this is one of the most common non-communicable diseases that people around the world in many different countries face. And actually, we can provide palliative care for people with heart failure, with high blood pressure, with uncontrolled cardiovascular disease. So that might be something you've learned today. Number two, all individuals with life-limiting conditions require specialist level palliative care. So it looks like there was about 60% of people said this was true and 36 said false. But the correct answer is actually true. This goes back to the image that Dr. Zippy had shared with us, that triangle image, that actually only a few people with very complex advanced symptoms need specialist palliative care. As healthcare workers, we can all begin to provide palliative care approach to our patients in need. So hopefully you'll begin to be more confident and have more skills as we go through this course. And the third one is, which of the following statements describing palliative care is correct? So it looks like nearly all of you got this right, which is great. The correct answer is palliative care includes emotional support for patients and their family members. And that's focusing again on family-centered care. We believe in palliative care, we need to look at not only the patient, but their caregivers, their family members, whoever they say their family is, we need to include them in the care that we are providing. So thank you so much for participating in that. There was a question that was put forward. Maybe I'll put this out to Vicky, if you're still with us, Vicky. There was a question, how can I train the community in palliative care while most of our community is illiterate? Vicky, are you still with us? Perfect.
Yes, I am still with you. It's not only your community that is illiterate, and many times for us, we have a belief, even a person who has never gone to school knows something. Because the community where we come from have informal education. Therefore, if it's an issue of a language, when you're using English, there are people who use their local language. Therefore, you have to bring a translator and you use the commonest language possible for them to understand. Everyone is trainable and they're very helpful in the community. We have the community volunteers that stay, that is the health center one. They stay with the patients and the patients take the last breath at their hands. Therefore, it's good to train them in palliative care. Thank you so much.
Thank you. So just if there's any final questions, Makulin, would you like to share any comments on behalf of KEPCA for our call today?
Thank you, Erin, and thank you all our participants. It's been quite an interactive session. I've really enjoyed it, and I've enjoyed the input and the feedback and the discussion. On behalf of KEPCA, we are happy that even through these sessions, we are coming up with some of the areas of need that we can look through and even support. And Vicky, the last comment has brought out something which is very important, talking about speaking in the language that people understand, language in terms of not necessarily English, but even the nonverbal languages, or just looking into what are the social norms which can affect or can enhance the way we provide palliative care. So that's a key thing to think through. And as we think at the humanitarian setting, there are some things which may not be spoken, but may not be understood by people from outside, but people who are within the practice and people who work there. So even as we continue with these sessions, it would be good to hear from the people who work in these settings. What are some of the elephants which are known only in the humanitarian setting that affect palliative care, either positively or negatively, can enhance or can affect barriers to palliative care provision, which may not be written on a paper, but it's really known and within the setting. And I think that can be really helpful, even as we look into tailoring culturally appropriate services for palliative care for all in need, wherever they are, whatever time they need. So thank you so much and keep coming. We believe that after these sessions, we're going to be better people and we're going to have the knowledge and skills to provide better care to our people. Thank you.
Thank you, Maculin. There was one more question that came through and I can answer it just as we are closer to time. How can psychological support help in the alleviation of chronic illness symptoms? So when we talk about chronic illness or non-communicable diseases such as high blood pressure, diabetes, these sorts of things, we actually need to acknowledge that patients, not only in urban settings, but in refugee camps, have been dealing with symptoms that have been difficult. They've been told by the medical team to change their behavior for many, many years.
Hi. Hi, all of you.
Sorry, everyone. Sorry about that.
Hi, we can hear you.
So I think psychological support for patients like this who have chronic illness is actually extremely important, but often lacking. So we'll go further into that. We have multiple sessions talking about psychological and social support for patients, as well as how to communicate. We'll be talking about that at length. Dr. Ali is our representation from the Non-Communicable Disease Alliance. So if you did want to reach out to her specifically about a specific disease that you're struggling with in your facility or where you work, then I'm sure she'd be happy to reach out to you. She's based in Nairobi, Kenya. All right, I think we'll probably end there for today. We have shared our email address as well as the WhatsApp group. So please do reach out to us if you have any questions or difficult cases. We are here to support you. So again, thank you for participating today, and we'll hope to see you next week. Again, same time, Tuesday at 4 o'clock. You're welcome to join on Tuesday, May 31st. Thank you everyone so much. Have a really great week.
Thank you very much.
Thank you very much.
Thank you
Very much,
Thank you
everyone.
very much.
Thank you very much.
Bye.
Bye-bye.
The lesson has been interesting. Bye-bye for me.
Thank you very much.
Thanks everyone.
Thank you very
Great
much.
to see you all.
Bye-bye.
All right.
Bye.
Next time.
Thank you.